Discover the two key distinctions you must know when evaluating acute neurologic decline with low sodium. EndlessMedical.Academy educational case. Content created, reviewed, and approved by Lukasz Kiljanek, Doctor of Medicine, Board-certified nephrologist, Certified Hypertension Specialist, Internal Medicine Specialist. See video description for disclosures. A 23-year-old man is brought to the intensive care unit after a generalized seizure at an outdoor music event. Friends report that he had been drinking large amounts of plain water and beer for several hours. His history includes paroxysmal atrial fibrillation, immunoglobulin G4-related disease, hypersensitivity pneumonitis, and varicocele. He has no known allergies. He drinks alcohol heavily, exercises 3 times per week, has a past history of methamphetamine use, and lives with cats. Medications are apixaban, metoprolol, prednisone, and azathioprine. Family history is notable for atrial fibrillation in his father and autoimmune thyroid disease in his mother. Prior records include normal visual field testing during headache evaluation, an abdominal ultrasound showing mild hepatic steatosis without ascites, and a sputum culture from a recent cough showing normal respiratory flora. Current vital signs show temperature 36.9 degrees Celsius, pulse 139 per minute, respiratory rate 28 per minute, blood pressure 126/96 millimeters of mercury, and oxygen saturation 97% on room air. He is postictal and agitated with no peripheral edema and no focal weakness once sedation briefly lightens. Laboratory studies show sodium 109 milliequivalents per liter, potassium 3.7 milliequivalents per liter, glucose 104 milligrams per deciliter, blood urea nitrogen 8 milligrams per deciliter, creatinine 0.8 milligrams per deciliter, and serum osmolality 224 milliosmoles per kilogram. Magnetic resonance imaging of the brain obtained after initial stabilization shows diffuse sulcal effacement and mild cerebral swelling without hemorrhage or infarction. Which pathologic process best explains his acute neurologic deterioration? Option A, extracellular dehydration of brain cells from marked plasma hypertonicity. Option B, delayed oligodendrocyte injury causing central pontine demyelination. Option C, immune complex vasculitis with fibrinoid necrosis of cerebral vessels. Option D, astrocytic and neuronal osmotic water influx causing cytotoxic edema. The correct answer is option D, astrocytic and neuronal osmotic water influx causing cytotoxic edema. This patient has acute symptomatic hypotonic hyponatremia. After several hours of drinking large amounts of plain water and beer, he presents with sodium 109 milliequivalents per liter, serum osmolality 224 milliosmoles per kilogram, seizure, postictal agitation, and magnetic resonance imaging evidence of diffuse sulcal effacement and mild cerebral swelling. In acute hypotonic hyponatremia, extracellular tonicity falls before the brain can adapt by extruding osmolytes. Water then shifts into astrocytes and neurons, producing cytotoxic cerebral edema and increased intracranial pressure. Delayed pontine demyelination is a different process. Osmotic demyelination syndrome classically follows overly rapid correction of chronic hyponatremia, not the initial presentation of acute water intoxication. This patient is deteriorating while still profoundly hyponatremic and swollen. Likewise, extracellular dehydration of brain cells occurs in hypertonic states such as hypernatremia or severe hyperglycemia, but this patient has a clearly hypotonic serum. Immune complex vasculitis with fibrinoid necrosis also does not fit. The vignette already provides a strong metabolic explanation for encephalopathy and seizure, and the brain magnetic resonance imaging shows edema without hemorrhage or infarction. He also has no focal weakness when sedation lightens. Immunoglobulin G4-related disease is a fibroinflammatory disorder, not a classic immune complex cerebral vasculitis. In summary, the correct answer is acute hypotonic hyponatremia causing osmotic water entry into brain cells with cerebral edema. the demyelinating, hypertonic, and vasculitic alternatives do not match the timing, laboratory data, or imaging. Teaching points. Severe neurologic symptoms in acute hyponatremia reflect brain edema, not just a low sodium number. A second key distinction is timing. Osmotic demyelination syndrome becomes a concern after overly rapid sodium correction, especially in chronic hyponatremia, alcoholism, malnutrition, or liver disease. Don't forget to like, subscribe, and share. Content created, reviewed, and approved by Lukasz Kiljanek, Doctor of Medicine. See video description for disclosures.